Let's talk about brace treatment. The efficacy of braces has been demonstrated in a number of high-quality studies and is supported by a Cochrane review. Therefore, the use of braces is an effective, although involved treatment that must be carefully planned and implemented. The experience of the orthotist is critical in the fabrication of the brace, while the acceptance of the brace by the patient obviously depends on the experience of the treating physician. For this reason, this treatment should be reserved for a treatment team that treats at least 50 scoliosis patients per year with braces or under the guidance of an experienced specialist. There is an interdependent relationship between the result and both the corrective effect and the brace wearing time. The orthotist and physician must ensure good correction and variability, and the patient must ensure compliance. Wearing a brace is necessary when it is suspected that physiotherapy alone will not be sufficient. Previously, it was thought that orthotics could only be effective up to a 40-degree curvature. However, beyond this limit, there are positive results with the use of bracing as we know it today. This image shows the progression of adolescent idiopathic scoliosis in an adolescent boy to a curve of 56 degrees at the start of treatment. Thereafter, the radiographic curve is reduced, markedly compensated, and clinically almost invisible. Considering that surgery for adolescent idiopathic scoliosis is only relatively necessary when there are severe psychological problems due to cosmetic changes, brace treatment becomes even more important for larger curvatures. It has been shown that there is no increased risk of serious cardiopulmonary problems in adolescent idiopathic scoliosis or late onset scoliosis of unknown origin, especially since a curvature of 80 to 90 degrees, with its problems might be expected, is virtually never reached even without treatment. In addition, there is evidence that late onset scoliosis, with the onset between the ages of 10 and 14, does not lead to chronic pain syndromes in the first decades of life, and adult patients usually do not suffer from disabling pain later in life. Therefore, surgery in this group is only necessary when the spinal curvature causes immense psychological distress. There is a real chance of achieving clinical corrections comparable to those after surgery if modern bracing standards are used. The provision of bracing to scoliosis patients is a responsible task for physicians and orthotists, which, if properly performed, can generally not only prevent further deformity of the trunk, but also provide significant cosmetic improvements in cases of residual growth. However, such improvements can only be achieved if the three-dimensional trunk deformity of scoliosis is optimally addressed. It has been shown that the best cosmetic results are achieved with a curvature correction of more than 20 degrees and significant derotation, assuming an appropriate wearing time. Viewed from the side, patients treated in this way not only have a near normal trunk shape, but also near normal spinal function. Let us take a closer look at the types of trunk braces used in scoliosis therapy. Scoliosis braces vary widely in quality and effectiveness. Most cast-based braces bear the signature of the orthotist or technician who made them. The use of computer-aided design and computer-aided manufacturing, which we call CAD/CAM, may be safer for the patient. CAD/CAM fabricated braces, which utilize extensive expert-based databases, are ideal for use with all types of scoliosis. In addition, such expert-based quality management can reduce potential sources of error and ensure a standardized and reliable design, resulting in more comfortable outcomes for the patients. In this image, we have two different Chenot style braces on the same patient. On the left, there is a cast-based brace for a double major curve, thoracic to the right and lumbar to the left. In the brace, the trunk orientation appears unchanged. On the right, the same patient in a pattern-specific Gensingen brace, GBW, where the trunk orientation appears to be altered, thoracic to the left and lumbar to the right. It is reasonable to assume that the latter brace will have a greater effect on the curve than the brace on the left side. For a number of years, there have been some high-quality systems available that allow the fabrication of high-quality braces without the need for a plaster cast. Here we see a 13-year-old girl with a thoracic curve of more than 50 degrees at baseline, treated with a Chenot Gensingen brace, GBW, and at the end of treatment, there is good balance and trunk symmetry. In the meantime, it has been shown that not only it is possible to correct higher degrees of scoliosis with modern CAD/CAM Chenot braces, but that successful brace treatment in such cases can also achieve cosmetic improvements comparable to or even better than surgery. The correction effect of the brace expressed as a percentage of the initial value determines the end result within certain limits. But is it worth wearing braces if the correction is relatively small? In general, correction is very important. According to Landauer, at least 40% of primary correction is necessary for sustained improvement. Therefore, the goal should be to consistently exceed this percentage of correction to ensure that the treatment is worthwhile. However, in some cases of very stiff curves, this goal cannot be achieved even with the most advanced braces. With the Genzinger brace we have seen clinical or cosmetic corrections, even when, in rare cases, there was no significant improvement in the curve on the radiographs. Curvatures beyond the 60-degree limit can rarely be corrected by more than 50%. In these cases, the absolute correction achieved, expressed in angular degrees, may be better for prognostication than a percentage of correction. In our experience, for curves greater than 50 degrees, a correction of at least 15 degrees should be achieved to stop progression. With a correction of 20 degrees and more, we have been able to achieve permanent correction even in curvatures greater than 50 degrees, provided, of course, there is some residual growth. So how do you learn to wear a Genzinger brace? After the trial fitting and initial adjustments to improve comfort, the brace should be worn as consistently as possible. In most cases, simply opening the buckles of the brace for 15 to 20 minutes is sufficient to allow the skin to recover. With this strategy, the body can usually tolerate more than 20 hours of brace wearing on the first day. In general, the body can tolerate 23 hours of continuous wear in less than a week. However, if patients have trouble sleeping while learning to wear the brace full time, it is recommended to wait 3 days before trying to wear the brace again at night. During the break-in period, any discomfort should be taken seriously, so it is extremely important to identify and eliminate problem areas so that by the end of the break-in period, only the necessary pressure points are felt comfortably.